to discuss something in constructive way, he will always only when it is required, and whenever he will speak, it will be a very good idea. So Sachidanand otherwise is basically Estonian from in the from AIMS only senior residency and DM, and then he joined our department as a faculty. He has got almost 190 almost 90 publications, and he is also having intense interest in neuropalliative care. Uh, he did his MBBS and MD from Patna, and after that he joined AIMS as a senior resident, and then he joined our department. And Sachidanand, everybody is waiting to hear what is new in this area and what exactly we should do when a patient is having symptoms of this kind. Thank you, Sachidanand.
Thank you, ma'am, and good morning to all of you. And thank you, IAPC, for giving me this opportunity. Today, I will be speaking about approach to an adult patient.
Not able to hear you very well, Sachidanand.
Okay, let me check. So the outline of discussion would be mechanism. I'm audible now, Arun?
Slides are not visible.
Yes, yes. Slides are like chalu nahi hua hai. I will open the slide. You are audible. Carry on.
Okay, so the outline of discussion would be mechanism, assessment, and management of anorexia, cachexia, and fatigue.
सचिदानंद स्लाइड्स नहीं दिखाई दी हैं, तुमने शेयर करना चालू किया क्या नहीं किया अभी?
यस मैम, शेयर तो किया है.
नहीं, आई थिंक पहले अपना पावर पॉइंट ओपन कर लो अपने लैपटॉप में और फिर शेयर स्क्रीन. यू आर को होस्ट ऑलरेडी.
Okay, just give me 1 minute more. Why it's not coming? Decreased appetite, fatigue, weakness, social withdrawal, sleepiness, sadness, lack of motivation, hyperalgesia, and failure to concentrate. So these are the constellation of symptoms which the patient presents with anorexia, cachexia. Now the causes of anorexia can either be peripheral or central. In peripheral, number one is mechanical impingement by the tumors, and in this group, CA esophagus, CA thyroid, and mediastinal masses or lymphomas where there are large lymph nodes in the mediastinum. There they can block the digestive tract, and this may lead to anorexia. Others like tumors which produces substances which alter food intake, and these are the excess production of lactate, tryptophan, and parathormone related peptides. And this is seen more in AML cases, carcinoma of breast, GI malignancies, and gynecological malignancies. Because of the alteration in the nutrients like zinc deficiency, especially in esophageal and lung cancers, and because of the production of cytokines that alter secretion of GI peptides and also affects the gastric emptying time, and this leads to alteration in food intake and subsequently anorexia. And chemotherapy agents, they alter taste, cause nausea and vomiting, mucositis, abdominal cramp, bleeding, and ileus, and as a whole they causes decreased food intake. The central causes is basically because of alteration in the central neurotransmitter mechanism and the associated hypoxia. So the primary mechanism involved here is that tumors, because of the various neurotransmitters, or they alter the neurotransmitters in the brain that cause increased satiety. So they inhibit the satiety center and cause anorexia. Few words about the central effect of chemotherapeutic agents like methotrexate. It decreases opioid-mediated feeding and activation of brain pathway associated with dehydration. Tamoxifen, it inhibits the fatty acid synthase in hypothalamus, leading to accumulation of malonyl coenzyme A, and increased malonyl coenzyme A is associated with anorexia in cancer patients. And as a whole, all chemotherapeutic agents, they activate neurokinin 1 receptors, leading to emesis and causes anorexia. And the pathophysiology, the central, as we know, the satiety center of human body lies in the hypothalamus. So the hypothalamic neuropeptide circuitry is altered. It is usually altered in two ways: by the inactivation of neuropeptide Y and agouti receptor peptide neurons, and activation of pro-opiomelanocortic POMC and caffeine amphetamine receptor transmitter neurons. So in hypothalamus, the orexigenic signaling pathway that increases or that causes satiety is blocked by the cytokines mediated leptins, and this is the primary mechanism or centrally and the central cause for decreased satiety leading to anorexia. In the cytokine 1, the interleukin 1, interleukin 6, and tumor necrosis factor alpha. These are the three potent cytokines that block the neuropeptide Y signaling pathway in hypothalamus. And of these, the interleukin 1 is the most potent anorectic cytokines. It reduces the size, duration, and frequency of meals. These cytokines, they directly cross the blood-brain barrier or by activating the ascending pathway of the vagus nerve to release interleukin 1 in the central nervous system, stimulates the cancer-related anorexia and fatigue. And these are secreted by either the tumor cells or in response or by the immune system in response to the malignancy. At the cellular level, there is the inhibition of AMP kinase leads to less production of ATP and less storage of ATP, and this leads to anorexia, subsequently cachexia, and this is also mechanism involved in cancer-related fatigue. So as it can be seen in this photograph, that the cytokines either they through the vagus nerve or after crossing the blood-brain barrier, they inhibit the AMP kinase through different mediators like melanocortin, tryptophan, which leads to increase in serotonin levels in the brain, and which further increases the corticotropin and it inhibits the AMP kinase. Also, the inducible nitric oxide synthase, this also inhibits AMP kinase. So at the cellular level, inhibition of AMP kinase is the primary mechanism involved. And at the cellular level and at the central level, inhibition of hypothalamic satiety centers lead to anorexia and further decrease in weight and body muscle mass and fat content. So the AMP kinase, which is the cellular energy sensor responding to low ATP levels, and this is not activated, or at cellular this is inhibited by these pathways and these mediators. Similarly, lactate in cancer cells, the tumors causes increased glycolysis leading to increased LDH levels. LDH crosses the blood-brain barrier, and with the similar mechanism, it inactivates or it inhibits the AMP kinase, leading to accumulation of malonyl coenzyme A, which is involved in the fatty acid synthesis, and this increased malonyl coenzyme A causes anorexia. Now the role of neuronal nitric oxide synthase. Here again, as we can see, the neuropeptide Y, renin, and orexin A, these are the orexigenic signaling pathways mediators, they acts on the hypothalamic receptor, and via neuronal nitric oxide synthase it stimulates or activate the AMP kinase. But because of the the different mediators which are released because directly by the cancer cells or in immune response to cancer cells, these causes inactivation of AMP kinase and hence anorexia, which further leads to cachexia. So in nutshell, cancer cells, either because of the tumor products or the immune system through cytokines, they cause and metabolic abnormalities leading to lipolysis, protein loss, and anorexia, and these all processes leads to cachexia in long run. Now coming to the effects of cachexia, the skeletal muscle metabolism during cancer cachexia, the skeletal muscle metabolism is altered, and this leads to loss of skeletal muscle mass. The primary mechanism involved is increased apoptosis, proteolysis, and branch chain amino acid oxidation, and decreased protein synthesis, amino acid transport, and regeneration. And the protein degradation leads to proteolysis of myofibrillar proteins in the muscles. So proteolysis that leads to increased caspase activity and apoptosis. Insulin-like growth factors, which normally stimulates protein synthesis via AKT and mTOR, is decreased, suppresses protein synthesis, and there is increased protein degradation and apoptosis. So the loss of muscle mass and function is because of reduced regeneration, increased apoptosis, and increased proteolysis, decreased protein synthesis, decreased amino acid transport, and also there is a increased branch chain amino acid oxidation in cancer cachexia. The changes in adipose tissue are there is increased lipolysis, decreased lipogenesis from glucose, and impaired entry of fatty acid owing to decreased activity of lipoprotein lipase. So the causes the causes of adipose tissue loss or fatty tissue loss in the body in cancer cachexia is increased lipolysis, and there is simultaneously decreased lipogenesis from glucose, and the fatty acid metabolism is impaired. Also, the two types of adipose tissues lies in our body. One is the white adipose tissue and one is the brown. So there is more or increase in brown adipose tissue, and brown adipose tissues are only responsible in the thermogenesis. So more of adipose tissue is metabolized to increase the thermogenic activity, which is not much useful for the body, whereas gradually this white adipose tissue decreases, and that leads to loss of fat mass. Also, the resting energy expenditure is increased in cachectic patients with futile metabolic cycling. And it has been seen that it is increased in pancreatic and lung cancer as compared to healthy subjects. So the resting energy expenditure, which is not for the active period, or it is the energy lost while we are on rest. So this is the more of energy is wasted while we are resting, and hence the patients who are cachexic, there is increase in resting energy expenditure, and there is increase in protein catabolism, which could relate to utilization of skeletal muscles and decrease in muscle mass. So the tumor, because the tumor cells are consuming much of the glucose, much of the, like, it affects all the aspects of metabolism, whether it is amino acid, glucose, or fatty acid. and simultaneously they cause a catabolic state in the skeletal muscles, in the bones, also in the liver and the fatty tissues, in the brain and the GI tract. So as a whole, the catabolic process is increased and the anabolic process is decreased, leading to gradual loss of weight and a stage of cancer cachexia. For assessment, the model adapted for cancer cachexia is storage, intake, potential and performance model, the SIPP model. So in storage, the assessment is done for usual weight 1, 3 and 6 months prior to the current weight, speed of weight loss corrected for fluid retention or obesity, deficit of a specific nutrient, muscle mass measurement from CT scan. Intake, the assessment of intake is whether patient has anorexia or not, early satiety, nausea, vomiting, disturbances of taste or smell, other GI symptoms, percentage of normal intake, diary for 1 to 2 days, and assess calorie and protein gain. The potential means whether the treatment is effective or not, or any treatment can be given for the primary malignancies. And here we assess the tumor catabolic activity, the inflammatory markers, the modified Glasgow prognostic score, and the comorbidities. And performance status, cachexia-related suffering, and prognosis. So this is the model which is adopted for the assessment, and the tools which are used are Edmonton symptom assessment, or any of the tools can be used with the patient-generated subjective global assessment of nutritional status, or the functional assessment of anorexia, cachexia treatment, and for geriatric population of more than 75 years, a GA geriatric screening can be used. In Edmonton symptom assessment system, we assess the 9 symptoms: pain, nausea, tiredness, drowsiness, depression, anxiety, appetite, well-being, shortness of breath, and each symptom is rated along a numerical scale of 1 to 10, and it is a self-reported one. In the patient-generated subjective global assessment of nutritional status, patient assessed weight loss, nutritional impact of the disease, the food intake, the functional capacity, and physician evaluates the disease and its related nutritional requirements. So in this tool, 4 aspects is assessed by the patient, and the disease status and its nutritional requirement by the physician. The FACT tool, it assesses quality of life together with appetite and eating sub-scale, and can be used to assess symptoms such as anorexia, early satiety, nausea, taste, and smelling disturbances. And in geriatric patient, the geriatric screening scale is used for assessment of nutritional status as per their age. The CT scan is also used to assess the muscle mass, because the muscle loss can be hidden by weight gain due to ascites or peripheral edema, or in cases of sarcopenic obesity, when depleted muscle mass is masked by obesity. The methods of muscularity or the muscle mass assessment in Cachectic patient, either by the lumbar skeletal muscle index, it is determined by the CT imaging. The appendicular skeletal muscle index, which is determined by the DEXA scan, and the whole body fat-free index without bone, determined by bioelectrical impedance analysis, and mid-arm muscle area determined by anthropometry. And these are the cutoff values for the muscle depletion. Now coming to the psychological aspect of the cachexia, the patients are are in a psychological stress when the cachexia is set in. This is because there is a visible change in their body structure. They feel they are less attractive. The feeding is different. That leads to weakness, loss of appetite, heightened sense of self, awareness of changes, speed of weight loss, and feeling old. And they're not able to stop the weight loss and reverse the effects. The life is restricted because of challenges in autonomy, because of extreme weakness. They may be get dependent on others for their daily activities. They are not able to socialize, and the exhaustion is very high. So these all leads to the psychological impact on the cancer patients who are in the state of cachexia. So the coping mechanism is very important, because when the coping mechanism is good, then these patients, even if they are in cachexic stage, their quality of life is better maintained as compared to those where coping mechanism is not good. So the acceptance of limitation around nutritional intake and of terminal nature of disease, this is the key element of coping. So those who accept this, they are able to maintain a better quality of life. The loss of desire to eat was not equated to loss of control, and this prompted self-worth by overcoming negative feelings. Any nutrition-related actions should be patient-driven, and it should not be guided by the caregivers or the physician in the state of cachexia. And by monitoring their dietary habit, patient discovered what worked for them. So this is again a patient-driven approach of coping, and by continuously lowering the expectation, so that is the acceptance by the patient, and the humor and reminiscence about past achievement regained space, and that improving the relationship. So meaning that the coping mechanism is very important, and those who cope well, who accept it, they are able to maintain a good quality of life even in their terminal stages due to cachexia. Management wise, patients either can be managed by pharmacological or non-pharmacological methods. So the non-pharmacological methods, patients with anorexia from decreased physical activity, concomitant infection and toxicities to the alimentary tract from chemotherapy and radiotherapy are managed symptomatically by maintenance of nutritional status and quality of life. This includes if there is stomatitis, or by correction of correctables like stomatitis, nausea and vomiting. If there is nausea and vomiting, frequent small meals and antiemetics, antibiotics if there is concurrent infection, blood transfusion where required, and use of oral and parenteral nutrition if required. Now the pharmacological managements include corticosteroid, progestational drugs, prokinetic drugs. The corticosteroids most commonly used for cancer cachexia are dexamethasone, prednisolone, and the optimal dose of prednisolone is 40 milligram, which is equivalent to 6 milligram of dexamethasone. An advantage of dexamethasone is that it can be given subcutaneously. The progestational drugs are medroxyprogesterone and megestrol acetate, and the starting dose of megestrol acetate is 40 milligram. The prokinetic drugs have a role in patients who have nausea and vomiting, and also where the gastric emptying is delayed. So the mechanism of action involved for steroids, they have an efferent effect. They decrease prostaglandin metabolism, that decreases the interleukin-1. The progestational drugs, they again have an anti-inflammatory property, and also they causes decreased levels of serotonin, and indirectly increases the appetite. Cannabinoids can also be used, but because of their anti-emetic effect, and they increase appetite. The serotonin antagonist Cyproheptadine, it can also be used. Metoclopramide sensitive the prokinetic agents, they are used in patients with nausea and vomiting, and where the gastric emptying is anabolic steroids like nandrolone decanoate and fluoxymestrone. The inhibitors of phosphophenol pyruvate carboxylase can also be used. So as we can see that the different pharmacological agents which are used for management of anorexia, cachexia, the primary mechanism involved is their anti-inflammatory property leading to decrease in the level of cytokines and their immunomodulatory function. The amino acid supplements are also used. The anti-inflammatory like endomethacin and ibuprofen, the melatonin hormones, and a combined approach where a combination of progesterone hormone, ibuprofen, and this appear to reverse the weight loss and appear to improve quality of life in patients with advanced GI cancer. The other results are the carnitine supplements and celecoxib are also useful. And a 4-month course of this is a pilot. This is results from a pilot study. A 4-month course of methoxyprogesterone acetate and icosapentaenoic acid enriched nutritional supplements, carnitine supplement, thalidomide, or a combination of all 4 interventions are beneficial in cancer patients. But such results are only from a limited study and cannot be applied to all patients. Now coming to the parenteral nutrition, and the parenteral nutrition is justified when an identifiable and reversible cause of weight loss is identified, and but there is no increase in survival, no improved effect on the tumor cells, a minimal decrease in toxicity of chemotherapy or radiotherapy, and minimal decrease in surgical morbidity. So TPN, they can be used, but for a shorter interval, and they may not have any effect on, or they may not have a survival benefit. So the benefits of TPN can be improved wound healing, decreased rate of infection, fewer major complications, and decrease in the post-operative mortality. But TPN is considered beneficial in patients who have not been eating for at least 10 days or in those who have lost more than 10% of their usual body weight. But use of TPN is also associated with refeeding syndrome, because in case of catabolism and malnutrition, there is decreased insulin and increased glucagon. So the glycogenolysis, protein catabolism, and gluconeogenesis is are increased. And when we feed when we give the patients with a lot of carbohydrate, there is rise in insulin levels, increased protein synthesis, and subsequently there is retention of salt and water, and also the thiamine use is also increased. There is intracellular shift of phosphate, magnesium, and potassium. So the patients having may develop hypophosphatemia, hypomagnesemia, hypokalemia, thiamine deficiency, and salt and water retention. So this is very commonly seen in patients who are in the cachexic phase and given TPN. So this should be kept in mind while giving patients TPN in advanced cancer stages. So this is another trial, that is a MANEC trial, where a multimodal approach is used for cancer cachexia. Here, exercise, nutrition, and anti-inflammatory medication for cachexia is used. And this intervention is based on evidence to date and consists of non-steroidal anti-inflammatory and icosapentaenoic acid reduced inflammation, a physical exercise program using resistance and aerobic training to increase anabolism, as well as dietary counseling and oral nutritional supplement to promote energy and protein. But this trial is in phase 3 right now, and we hope that after the completion of this trial, we may get results which can be applied to cancer patients. Now, for future trends in the management of anorexia, uh, anti-interleukin 6 monoclonal antibodies, they may be a promising option. Also, the interleukin 15, a cytokine expressed skeletal muscle, is able to suppress the increased DNA fragmentation associated with muscle wasting and slow muscle wasting. And these are in their preliminary animal research stage. Beta-2 adrenergic agonist may also be beneficial, and selective androgen receptor modulators, but these are under development, and we may get in future if they found to be effective. Brief words about the stage of cancer cachexia. The cancer cachexia precedes pre-cachexia, and when it leads to refractory cachexia and death. So the pre-cachexia is a stage where weight loss is up to 5%, and anorexia and metabolic changes occur. Cachexia is when weight loss is more than 5%, or BMI is less than 20 and weight loss is more than 2%, with sarcopenia and weight loss more than 2%, and often reduced food intake and systemic inflammation. And in refractory cachexia, there is variable degree of cachexia, and cancer disease both pro-catabolic and they are not responsive to anti-cancer treatment. Patients have low performance score and survival is of less than 3 months. So the cancer cachexia can be defined based on the cancer cachexia study group definition or European Palliative Care Research Collaboration or the Evans-Settle criteria, and also the ICD-9 criteria. So they use different variables for definition of cancer cachexia. Now coming to the cancer-related fatigue, the second part. So the cancer-related fatigue has been defined as a distressing, persistent, subjective sense of physical, emotional, or cognitive tiredness or exhaustion related to cancer or cancer treatment that is not proportional to recent activity and interferes with the usual functioning, meaning that the normal functioning of the patients may cause tiredness in patients who are in a stage of cancer-related fatigue. Its prevalence is found in up to 99% depending on the patient, the type of treatment received, and the method of assessment used. And up to 2/3 of the patients are having moderate to severe fatigue. The causes of cancer-related fatigue is multifactorial. It is because of the malignancy itself or the cancer treatment, the ongoing pain because of anemia, fatigue which is pre-existing before the treatment started, other medical or comorbidities, lack of physical activity, nutritional problems, medications, emotional distress, and sleep problems. So the cause of cancer-related fatigue is multifactorial, and we have to think comprehensively while we try to treat it. So the mechanism of cancer-related fatigue is either because of impairment of mitochondrial function because of the inflammatory mediators or immune response dysregulation, or because of hypothalamic pituitary axis dysregulation. And there is also a genetic association where interleukin 6, SNPs, 174, TNF alpha. So few genetic makeups are found to have more fatigue as compared to other. For the assessment of fatigue, These unidimensional scales can be used, that NCC and intensity scale, the fatigue intensity scale, the Roten fatigue scale, the VAS score, and the Likert type scales. So these are the unidimensional scales. The advantage of unidimensional scales is that they are simple to use and they are less time consuming. But the other multidimensional scales can also be used, like the medical outcome study short form 36, vitality subscale, brief fatigue inventory, cancer fatigue scale, the Halder fatigue questionnaire, multidimensional assessment of fatigue or global fatigue index, and fatigue symptom inventory. These are the multidimensional scales. They are time consuming and they need training before they can be used by anyone. For management of cancer-related fatigue, we have non-pharmacological methods and pharmacological methods. In non-pharmacological one, exercise, cognitive behavioral intervention, rest and sleep, nutrition, and other complementary therapies like yoga and meditation can help. And in pharmacological treatment, erythropoietin stimulating hormones in anemic patients, psychostimulants, and L-Carnitine can be of use. So exercise, for exercise, the low intensity exercise matched to patient's comfort levels shows quality of life improvement, and timings can be 20 to 30 minute session, 3 to 5 times per week. And as per the American College of Sports Medicine, the cancer treatment, the cancer patients and survivor engage in at least 150 minutes of moderate intensity aerobic activity each week, and this can be beneficial. So in few of the selected group of patients, they also recommend, like in patients receiving marrow or stem cell transplant, aerobic interval training with appropriate monitoring, during chemotherapy and radiation therapy, home-based exercise programs, and men with prostate cancer undergoing androgen deprivation therapy, strength resistance exercises. Education, to educate the patients is very important. So self-management of their fatigue, also the consultation regarding nutritional deficiencies, and energy conservation strategy and activity management as per their fatigue. Cognitive behavioral intervention is very helpful, but it is found in not to be helpful in moderate to severe conditions, and NCCN guidelines for distress management recommend referral to a specialist and cognitive behavioral therapies. In mild cases, supportive care can be suffice, and it is advised to avoid caffeine, nicotine, and alcohol before sleep. For anemia, the published data suggests that the use of recombinant erythropoietin agents to increase hemoglobin levels in cancer patients with disease or treatment-related anemia may improve their vigor, fatigue, and other quality of life outcomes. And similarly, the pain should be managed adequately as per the WHO Magic Ladder. The sleep disturbances have been shown to be associated with fatigue, and the various studies have shown that when the sleep disturbances, the sleep disturbances or the lack of sleep or the lack of inadequate sleep, the chances of fatigue and cancer-related fatigue increases. So sleep disturbance in cancer can be due to anxiety, stress, and depression and pain. And the sleep that is inadequate or unrefreshing may be the important expression of fatigue. So the pharmacological agents for management of it includes the benzodiazepines and antihistamines, chloral hydrates, chlorpromazines, and a treatment strategy called chronotherapy. So the timing of administration of drugs which the patient is taking should be such that they minimize their side effects and maximize their therapeutic effect. So the potential pharmacological agents for moderate to severe are methylphenidate. These are the CNS stimulants. Donazepam, that is called cholinesterase inhibitors. Modafinil, this is also a CNS stimulant. Bupropion, it is an antidepressant. L-Carnitine is an amino acid supplement, and adenosine 5 triphosphate, that is a nutraceuticals. In last, the L-Carnitine supplement is shown to have benefit in patients with cancer-related fatigue, but the literature is very limited. So the proposed in this study, they have shown that the restoration of carnitine pool may alleviate the fatigue of cancer patients, and the improved nutritional status of patient, and did not require reduction in dose of the chemotherapeutic regimes, those who received L-carnitine supplementation, and also improved the nitrogen balance. And the L-carnitine has anti-catabolic effect. So, but this is a single study where such supplementation is used and found to be beneficial in chemotherapeutic agents. So, just to summarize, the anorexia, cachexia, the mechanism in cancer cachexia is complex and multifactorial. The neuropeptide and cytokines play an important role. The treatment modalities at present are dietary modification, appetite stimulants, drug against cachectic signaling molecules and mediators, meals of a small portion that are region for the patient, and it should be managed with the patient by itself. Patient with chronic nausea, early satiety, and gastroparesis through kinetics can be helpful. Slowly progressive illness benefits from magistrol acetate, and severely ill patients with multiple complex symptoms and limited life expectancy, a short course of chemotherapy, a short course of corticosteroids is beneficial. So we should avoid using long course of corticosteroids. It is beneficial only in patients who are terminal and for shorter period. For fatigue, fatigue is one of the common and distressing symptoms in cancer patients. The cancer-related fatigue may be influenced by multiple factors like the demographic, medical, cognitive, emotional, behavioral, and biological one. The elevated inflammatory process, alteration in neuroendocrine and immune system, as well as variation in inflammatory-related genes are the basic mechanism involved in cancer-related fatigue. Treat the reversible causes like anemia, infection, anxiety, depression, insomnia, and drug side effect. The most promising is physical activity and exercise. The non-pharmacological management includes the cognitive behavioral therapy, mindfulness, yoga, psychological support. So I just want to emphasize that in fatigue, the most promising and most effective is physical activity and exercise, and other pharmacological agents which are used are not of much use. So we should practice we should practice to encourage our patients to be physically active and do whatever exercise they can tolerate for cancer-related fatigue. Thank you.
Thank you, Dr. Sachidanand. I'll just put some comments from the chat box because there are not many questions. Okay. Yeah, you can unshare the screen now. Okay, Dr. Sachidanand, few comments from the chat box I'll just put in.
Yes.
So people have commented about management of anorexia, cachexia, and they have gone through the same things that we have mentioned, like non-pharmacological, pharmacological, steroids. So interesting comment here. Is anorexia and fatigue an essential part of dying process? Any comments on that, Dr. Sachidanand? Is anorexia and fatigue is an essential part of
Arun, can you
dying
repeat?
process?
Can you, Arun, please, can you repeat your question, because you are not. I'm not able to clearly hear you. Please repeat.
It is a comment. It is a comment. Is anorexia and cachexia an essential part of dying process?
Like not in all cases, but yes, as I have discussed, more it is more found in patients having pancreatic cancer, GI malignancies, and esophageal cancers.
Okay, thank you, Dr. Sachidanand. Any more questions, please, to Dr. Sachidanand? Dr. Sachidanand, there is one more question.
Yes, yes.
In the chat box, immune builders like colostrum, is it recommended?
Okay, I'm just going through the chat box. Let me see.
हाँ एकदम last में है.
Okay, in the end, like, so can immune builders like colostrum recommend? So when we see the scientific literature, there are not much of supportive evidence to use the immunomodulators in general. So there are very few studies and very limited literature which supports the use of immune modulators. So we have to primarily rely on the non-pharmacological methods for management of cancer cachexia, because even if you try to manage it, in the stage of cachexia, it's an ongoing process and we may not be able to correct it. So our idea is to maintain or improve the quality of life rather than to improve the body weight of the patient. So if you go on adding medications for management of cachexia, this is again a burden for the patients.
Okay, thank you, Sachidanand. Arun, there are no more questions?
There are some questions coming in. एक दो सवाल है.
Okay, go ahead then. Go ahead.
Dr.
Go ahead with
Sachidanand.
the question. We have time.
Yeah, we have some time. TPN in fatigue. Can you say anything on something on that?
If TPN can be used for shorter period of time, and it has been found that the TPN improves the quality of life of patients, because once they are on TPN for a shorter period of time, they feel better, but ultimately after a week, again they are in the same stage. So for a shorter period of time, yes, TPN can be given, but it's not indicated for longer period and for longer period of time.
Okay, thank you. And dose of magistral, dosage of magistral.
Yes, like Mestrol has been used in variable doses. People are using as high as like 160 milligram 4 times or 6 times a day. But again, the use of Mestrol is only indicated in patients who are having slow growing tumors, and also the response of magistrol acetate is not same in all patients. Few patients tolerate well, and few patients may complain of magistrol the nausea and vomiting after taking magistrol acetate, or they do not feel good after taking magistrol acetate. So the response is variable, and it is not used in terminal stages. It is only in patients who are having slow progressive tumor. There we can use, but not in terminal stages. And dose depends on the tolerability of the patient. So we'll start with the small doses and gradually we increase the doses.
Acha, there is one more question. Assessment of fatigue. Any specialized instrument or questionnaire that is used?
As I had discussed in the discussion, there are a few multi-dimensional tools, and any of these one multi-dimensional tools can be used. And like there is no gold standard tool for assessment of fatigue.
Okay, thank you. And one more, last question. That is, how long can TPN be continued?
If it is when feeding the patient, then when to take it off. Like the one indication to stop TPN is the side effects because of TPN. The side effects may be because of the TPN itself, or or because of the IV cannula or IV line which is inserted for TPN. So if patients have put on central line or PICC line, if they have a central or PICC line associated complication, then it should be stopped. Another thing, TPN, when you find that it is like as I told, it is only for the shorter period of time. It cannot be given for a longer period or for indefinite period. It looks like the patient is benefiting, but after some time, its effect ceases, and the patients may itself say that no, it's not working now. So it depends on the patient, and on the patient when they say that no, it's not working, then should stop it, because anyway TPN is not going to stop the cachexia process.
So, any other question, Arun?
No, thank you.
So I think thank you, Sachidanand, for a very good comprehensive overview of cachexia and fatigue. I think I want to tell you, I want to give a comment regarding TPN. TPN has a clear-cut indication only in the, if you are preparing your patient for any kind of surgery, then definitely TPN is useful. But in an advanced stage malignancy, only to handle cachexia and fatigue, I think TPN is of no use. There are clear-cut evidence. So please don't recommend TPN. And as Dr. Sachidanand said, anytime, if at all we are starting for the caregivers, they keep saying that give something, so we should not I think we should try to convince them, and if at all we are starting, we cannot continue for a long time, for more than a week, or because it is going to be harmful for the patient rather than useful. And I think three things work very well in my patient. I don't know, there are evidence about this, but three things works very well. Fatigue is common since beginning. At the time of diagnosis, patient start having fatigue. It is not because of any physiological changes, but it is because of their psychology. They start thinking about the cancer, and they start sleeping less, and they start getting fatigue, and they start eating less, and they just keep on thinking about the cancer only. So maybe because in the initial stage or in the middle stage or in the advanced stage, three things works very well, which are: first thing, ask your patient to do some kind of an exercise or some kind of a morning walk, even for 15 minutes or 20 minutes, if they will go out from their confined places. Otherwise, when a cancer patient is there, we keep the patient in the confined place, one room, and they keep thinking about the disease, and they get worsened. So ask the patient to do as much as possible, which from their body they should go out, and they should do some kind of a exercise, very mild exercise, which they can do, except in the cases where there is a bony metastasis and patient cannot walk or something like this. Second thing, which we should tell patient to keep themselves busy in as much as possible. Many a times what happens when patient is diagnosed with a cancer, they stop working and they stop doing their routine activity. School teacher will stop going to school, bank employee will stop going to bank. But if they can go with the whatever energy left, I think if they will keep themselves busy, it will make a lot of difference. And third thing, which is very very important, I think, rather than giving steroids and giving medication for anorexia and cachexia, I think we should try to take care of their sleep. If patient is sleeping well, I think they will be better, they will feel better, and whatever energy they have left, they will start eating also. And a small frequent meal work really well. So if we will not take care of sleep right from the beginning, patient is going to have fatigue and patient will feel weak. So please take care of sleep better than rather than taking care of other things. And sleep will be better only when you will explain patient better about the disease. And if at all there is any pain or some symptoms, you have to take care of those symptoms so that patient will feel better after when they will sleep better. So these are three things which I wanted to add. Any other comment, Arun? Otherwise, we can stop because we are already 4 minutes late.
No other comment. Thank you to.
No other comments. So thank you, Arun. Thank you, Sachidanand. And thank you, Nisha, as usual. She is keeping all of us on track. Thank you, audience. Almost 80 people joined today. And I think your presence really encourages speaker. And thanks a lot. Okay.